Hi guys, it's Dr. Eric Lindquist, CEO and founder of SonoPath.com, and I'd like to invite you to pass through your surgical or commuting day in veterinary medicine by listening to our podcast. Real talk in veterinary medicine from experienced professionals who aren't afraid to tell you how things really are so you can optimize your veterinary career and your process. Good day, everyone. This is Dr. Eric Lindquist. I'm the CEO and founder of SonoPath.com. Today, we're going to talk about what is the cost of missing a lesion clinically and sonographically in veterinary medicine. And I would imagine you could apply this to human medicine as well. But having done this for a very long time, both as a general practitioner and as a surgeon back in the day, having been a technician cleaning cages when I was 15, I've seen pretty much everything in veterinary medicine, and when you become a clinical sonographer and a mobile clinical sonographer doing a lot of volume over the years, you get to see the ins and outs of what happens in clinical workups by means of the ultrasound. And the reason I came up with this article and this idea is to help you, the listener, the client, the veterinarian, the veterinary technician, to help you make the right choices. And this article could be, the concepts in this article could be applied to any capital equipment purchase. But since my modality is primarily ultrasound and mobile ultrasound, or what we call the best of good enough, regarding ultrasound machines, I don't want you to make any mistakes in the purchase and the implementation of clinical sonography in your practice. And having been through the full spectrum from consumer standpoint back in the day to now to specialist and utilizer of multiple machines and management of teams with multiple machines, and having been in the back room of corporate decisions from the top down situation on how things are decided, as well as now with the implementation and the growth of SonoPath. We are a consumer-based company, and we're here for you. And this article kind of embodies that concept and what SonoPath is built for. And it's built for you to help you do your job better. And it's also here to help you not make wrong choices in clinical sonography primarily. And we'll start here, but we can go on and talk about CT. We can talk about other modalities as well. And this is the first podcast for SonoPath that we are going to bring multiple players in the industry from high to mid to basic level that we find interesting and applicable for podcast purposes. And so hopefully you're tooling down the road on your on a trip or going to your clinic, and you're looking for some motivation for the day, a thought process. Well, that's what this podcast is all about. So today we're going to talk about what's the cost of missing a lesion clinically and sonographically. So the implementation of ultrasounds evolved considerably from when I started performing ultrasounds back in 1996 with a mechanical probe and a mental imaginoscope necessary to interpret images in respect to pathology. It's amazing what we were able to diagnose back then, and now technology has improved vastly, and there's a vast array of image quality advancements and workflows and techniques and ultrasound machine competitive factors that play a role in any ultrasound implementation on any given patient. So it's not just turn on the machine, put the probe on the patient, come up with your image. There is a lot more preparation behind that process. Moreover, in today's world, ultrasound is extremely available in clinics compared to 1996 or 2006 or even 2016. In 2022 and 23, it seems that everyone has a probe in hand with a wide array of abilities used for obtaining diagnostic image sets, and even a more vast array of abilities for interpretation of presentations. And that's a huge difference. Image acquisition is one thing, and interpretation is another. So this variety of sonographer and specialist background behind the probe is nothing new, and has been the case since the early inception of ultrasound in practice going back to the 1980s. The difference today is that the hands on the probe have become significantly amplified with clinical sonography being an essential daily diagnostic tool to maintain and enhance quality of care in veterinary medicine. It's much more ubiquitous. It's everywhere. And if you're practicing without ultrasound readily available, you're losing time on the workup of that patient, I can assure you. So from an image acquisition and interpretive standpoint, we must consider the body type, the conformation of the patient, the sonographer's innate and trained adaptive ability. The best sonographers adapt. They adapt to different presentations that they are presented with and different body conformations. We have to consider the machine quality and acoustic power, which are crucial, and clinical support to ensure a complete image set is obtained. How are you taught? Are you getting a complete image set or not? And are they of adequate quality, right? So the quality of the image is obtained, for example, from a 2 out of 6 body score cat or a ferret or a 6 out of 6 body score Rottweiler, and everything in between changes dramatically, as do the sonographic techniques necessary to image all these body conformations adequately or optimally. So we must consider the search for the right ultrasound machine for the practice, the right sonographer to train for that purpose, and the appropriate instructional technique, which can seem endless, whether addressing an abdominal sonogram, cardiac presentation, echocardiogram, thyroid, eye, or even orthopedic ultrasound. So the consistently best results for your practice depend on your ability to thoroughly investigate all these key issues surrounding the ultrasound machine, surrounding those that drive the probe on the machine, and those that indirectly utilize it, right? Who's your referral base, and do they have the mentality of, if it's sick, it needs a probe to drive ultrasound in your practice to get that patient where it needs to go? So rapid selection of an ultrasound machine, or one given to you in a lab deal without thorough investigation, more often than not, unfortunately, leads to suboptimal utilization and frustration in clinical sonography, in your clinical sonography curve and its implementation. It may even result in machine quiescence in practice. And we see it over and over and over again. If you're given something for free, there's a reason for it. It's never for free. It's always buried in the price and the profitability. So I can tell you that from corporate experience, both on the consumer end and from the back room. Everything is always built in. So there's nothing for free. And if they're giving you something for free, it's typically something that is out of date, that they can't sell for primary price, right? And so they have inventory, they need to move it, they need to incentivize you, and they do that. Well, that's fine if you're getting a laser or even a DR system or some lab equipment for free, but don't pick an ultrasound as a free incentive, because it is a completely different entity. It's a different beast. You need to optimize your ultrasound machine first and foremost for your use, because you're going to make so many decisions based on the clinical sonography process, and the ultrasound machine quality is at the top of that list of priorities for you. So then we have to ask ourselves, what type of facility do we have? Are we working in fast scanning only? Okay, maybe you can get a freebie machine for fast scanning. Or if you have a cat practice, or you have cats and Yorkies all day long, okay, you can probably get away with the lesser machine. But if you're dealing with anything over 50 pounds, you need the machine that is going to be able to image those. And in most clinics that I run into, I have plenty of Labradors walking through the door. And so you need that machine that's going to adequately image that. Do we use the machine for guided synthesis and then wait for our mobile sonographer to complete the exam? Then we have to decide, what is a complete exam? Is it acceptable to not image the adrenals every time? Well, I would say no, and I'm going to explain why. But maybe that's the current mentality that you're working with. Do we just avoid the gastrointestinal tract and pylorus if the patient has ingestion in the stomach? My answer would be no, because you can image the pylorus with proper technique in every scan, no matter what the animal ate, and so it's just a matter of technique. And traditionally, the former scenario was the narrative, right? The stomach's full, so I can't image it. Well, we don't have time to wait for that patient to be NPO and have an empty stomach, we have to get through our day. So when you're a mobile sonographer and you're being resourceful all day long and you run into a full stomach, you work around it. Right intercostal, S-step, protocol, position 13. We give you the pylorus every time, no matter what's in that stomach. It's just a technique, right? Then you ask yourself, is imaging the common bile duct standard view or considered a specialist image? I say it's standard view because there's lots of pathology that lives in the common bile duct. You have to capture it, even if you don't know what it looks like, you have to capture it adequately with adequate resolution with a proper machine that will allow you to do that. Because I can't tell you how many times I've run into biliary carcinomas, mucoducts, gallbladder, or biliary stones, the duodenal papilla pathology, and second and third opinions. You don't want to be the first person on a corrective second or third opinion. You want to be correct the first time. And that's what you want to strive for. And that includes imaging the common bile duct every time. Even if you're not sure what it looks like, capture the image. Capture the video clip going through the portal hilus. All of these factors play into a central theme of not missing a lesion. And that's what we're about, right? So this article will address all the common and not so common pitfalls regarding ultrasound machine selection, education around clinical sonography, your technological workflow, your veterinary culture that influences, or veterinary culture influences associated with clinical sonography from the time of the clinical presentation of the pet to the outcome for any given sick patient. And all of these things influence your cost of missing a lesion. Recently, ACVR and EVD, European Veterinary Diagnostic Imaging Association, which is essentially the ACVR of Europe, these are the two radiology specialty organizations in the United States and Europe. They published a consensus statement for the standardization of abdominal ultrasound examination. Prior to that, to our knowledge, the only proposed standardized protocol presented in abstract or published format was that of the Sonographic Diagnostic Efficiency Protocol, our S-step protocol that I presented in 2019 at EVD Congress in Basel, Switzerland. And then it was published as an abstract following, as are all abstracts from EVD or ACVR. They're published in VetRad and Ultrasound. The good news is that the S-step protocol contains inherently all the elements of the ACVR EVD standards, and there's good correlation between the two. So if you're doing S-step already, great, you're already getting everything that you need. You're passing through all of the structures that they're recommending finding. But prior to these efforts, no protocol had ever been established as a point of reference for a full abdominal sonogram. As a colleague said, everybody takes a different road to Rome. Some people would start up by the liver, some would start by the bladder, some would start in the mid-abdomen. But there was no standard to follow, no progression to follow. And so each sonographer would approach the image acquisition differently and often incompletely without a standard, right? And so when you're reading that telemedicine, it's like, okay, where are they now? You know, that's kind of a question unless there's a standard protocol. Or if you're over-reading in-house another sonographer's image set, you know, where are they, right? Especially if you're only using still images, right? So this reality has been fundamentally detrimental to clinical sonography historically, and even more damaging the telemedicine process, because if you don't have your hands on the probe and the telemedicine image set is not complete and standardized, then we're always wondering, well, what's that, right? Or where are you coming from? Or what angle are you taking? Whereas if we know you're imaging that left adrenal, we know you're in S-step 5, for example. Or if you're imaging the right adrenal or right adrenal area and passing through the right kidney and the vena cava, we know you're in S-step 14, right? So, and you're progressing through that scenario. So that allows the telemedicine process to be tighter and a tighter symbiosis between the sonographer and whoever's overreading if there's an overread process in play. So these recent standardization efforts assist the veterinary ultrasound community in having a focused goal for each exam and should assist in the improvement of image sets moving forward, which is a great thing, because we've lived through some really tragic scenarios over the years because of a lack of a standard protocol, and there have been amazing amount of misdiagnoses, I assure you, for lack of complete image sets. So you can take a still image, for example, and you can make a pathology or non-pathology out of a still image very easily. And we'll talk about that in a minute, and why we need to implement video clips constantly in every case. The next step after you have a protocol is to ensure the machine selection and education around the machine sonographer, as well as the cultural factors that lead up to the sonogram, are all optimized. And what does that mean? Well, if we examine each one of those factors in this article, we'll make recommendations on how to optimize the sonographer's ability to obtain a standard image set in all patients, right? So let's start with the ultrasound machine. Ultrasound machines are the last thing to cut corners on when considering capital equipment purchases in veterinary medicine. Sonography is a heavily user-dependent modality. As we convert veterinarians and technicians into sonographers, as opposed to the human model where the RDMS trained sonographer at either 2 to 4 years of preparation, have semesters of higher learning in ultrasound physics and operational procedures and image optimization. Their job is to optimize the image and follow the human protocols so the specialist, usually radiologist or other, can read those images either in another room or across the world. And so they have a 2 to 4 year degree, usually a 4-year degree behind them in just imaging patients, right? That's it, and all the factors that go into it. So, when was the last time you heard of a human being scanned by a radiologist or even a generalist? RDMS technicians are always the ones that are doing the ultrasounds in human medicine. So the veterinarian and the veterinary technician don't have that 2 to 4 year training that an RDMS does. So this means that the maximization of the machine capacity proactively by the manufacturer and the distributor is essential for minimization of user error in veterinary medicine. We have to make it plug and play for the veterinary field, and because there just isn't that preparation involved. The vast majority of our sonographers have only a fraction of training compared to their RDMS counterparts in the human field. No matter what the title, even radiologists train in ultrasound modality only as part of their residency program. And it encompasses radiography, MRI, CT, as well as other imaging modalities along with ultrasound. And you have radiologists that love ultrasound, and they're very, very good at it. And there are radiologists that are functional at it, and there are radiologists that rather do CT. It's all a personality thing. Just like, I used to love to scan and be a surgeon, but don't give me a neuro case. And then there are people that love dermatology or love ophthalmology, but they don't like other modalities. It's the same within the specialties as well, right? So we must focus our training into what we need to know, simplification of the learning process, as well as proactively prepare the ultrasound machine for a point and shoot workflow as much as possible. As a career-long consumer clinical sonographer, as I have been, still love it, which is great. I'm very fortunate to having been almost 30 years in the industry and still love what I do. I always recommend focusing first on image resolution. Okay, image resolution, contrast appearance, acoustic power, probe frequency for the body conformations you're dealing with in practice, efficient knobology flow, and processing speed. So if you address all of these things proactively when you are looking for a machine, you will probably make a very good choice. Okay, the price is the price regarding ultrasound machine quality, as ultrasound purchases remain a get-what-you-pay-for scenario. And there's a lot of caveat emptor. Let the buyer beware, right? The stuff I see coming across advertised is insane, and nobody calls them out on it, right? Assuming pricing is categorized appropriately and you're not overpaying for the quality of the machine, despite recent trends and marketing angles that we see that may suggest otherwise, you really have to try out a machine and compare it to other machines on the same patients, on difficult body scores and difficult conformations, and get a head-to-head. That's the only way you can make a true, correct selection. Just as the lower end units improve, these handheld units and so forth, and this new technology that comes about, and they improve their image quality, and that's great, that's progression. But also the higher end units do as well. And the bar of the standard of care continues to evolve, just like it always has. Remember the radiographs. I don't know if you've been practicing a long time. Remember the radiographs that we used to remember, the dunk tanks, that we used to use in the 80s and 90s. I mean, we've come a long way in digital radiography, and the resolution has increased exponentially. Well, same thing with ultrasound. So there's a standard of care of 2022 that isn't a standard of care of 1992 or 2002 or even 2012. And that's the same for ultrasound. So everything progresses. And what's the standard of care today? Standard of care today is the best you can do, right? Within reasonable price range, no matter what the modality. So the interpreting experienced general practitioner specialist just recognizes more subtle changes with the advanced machine quality and image techniques implemented, right? So we see things now that we didn't see 10 years ago. But that's standard of care because we don't want to miss a lesion. Just ask any clinical sonographer with a career and business based upon obtaining the right consistent diagnostic result regarding optimal image sets and optimal interpretation. How about, and ask him or her about machine quality. Ask about the company support. Ask what they need to pay to have that level of ultrasound. Because if you're bringing ultrasound in practice, you have to strive to have better image quality than your mobile sonographer. It doesn't mean it's going to happen on day one, but you need to strive because the mobile sonographer is probably using a machine that's been around 3, 4, 5, 6 years, and maybe it's time for them to flip it out. So you have to not take their old machine, you have to buy the next machine that they would buy in order to be in the standard of care scenario for the next 5 to 7 years, which is the lifespan of an ultrasound machine. It's just like a computer, right? Your MacBook needs to be flipped out every 5 to 7 years. And that's because the image quality changes, processing speed changes, the file size gets bigger. It's the same thing with ultrasound machines. So ensure the personality of all these factors come in and fits with who you are as a practitioner, right? And you'll have a better long-term 5 to 7 year plus experience with your newly purchased and implemented ultrasound machine. The culture of clinical sonography, and I use the term clinical sonography because it's a combination of, we're not just reading images, we're combining the image interpretation with internal medicine and surgical concepts. And having been a surgeon myself and practicing internal medicine, being ABVP, and having hundreds of thousands of cases to my background, clinical sonography, I can tell you, is the best modality to get you where you need to go on any given case. So if you apply clinical sonography to every clinical case, and we use the term if it's sick, it needs a probe, it does nothing more than stay ahead of the patient regarding its ultimate clinical destination, whether it's surgical, whether it's medical, whether it's intensive care, whether it's oncological, or quality of life hospice, or a negative sonogram, which has huge value. And it's important to communicate the value of a negative sonogram. It's what we want to find, right? So we rule out all the badness that could be going on. I'd love to perform a multicentric study that would compare the last 3 months of sick patients that are admitted to any clinic that does not employ ultrasound on day one of presentation, clinical presentation, and calculate the time from clinical presentation to direct diagnostic outcome, where you take it to surgery, whether you have diagnosis of lymphoma, you have pancreatitis, and you're treating for that. And then calculate the time from clinical presentation to direct outcome and compare that time frame to that of a similar set of sick patients in a clinic that employs ultrasound with every sick patient that walks through the door and does it on day one. And a comparison of elapsed time from clinical presentation to definitive direction would be very illuminating. And I already know the answer, as does every clinical sonographer in my circles. It's why we do what we do. I really think we're cheating, because we can see exactly what's going on and interpret it when you have the experience to do so, or fall upon the resources to help you interpret, and instead of playing guesswork, right? But since we are scientists and at heart and culture, a retrospective study would be appropriate. And if you'd love to contribute to that, info@sonopath.com. I'd love to talk to you. We'd love to talk to you and create a multicentric study that would look at this. Our job as clinicians initially is to define a patient's therapeutic destination based on the clinical pathology at hand, whether it's a surgical case, a medical case, a garden variety pancreatitis, a Cushing's case, or a multicentric neoplasia to be defined by cytology and biopsy at the time of the sonogram. If there's no culture of if it's sick and needs a probe, then animals often sit and wait without a direction. With global diagnostic testing alone and lacking specific diagnostics to help rule in or rule out underlying clinical pathology. For example, imagine the patient, and you all have visualization of this if you're listening, because you're in practice, and you see this all the time. It's a common scenario that we run into clinically and from a telemedicine direct clinical sonographer standpoint. Imagine a patient with an inflamed gallbladder mucocele or surgical bile duct, but it's presenting clinically as quote-unquote pancreatitis, right? It's being treated as pancreatitis. Well, it may stabilize a little bit, but it's not going to get better. And this is a common occurrence in our caseload, as according to our studies, only a fourth of the abstract we did back for ECVIM many years ago, only a fourth of surgical biliary patients have visible icterus, and only half of them have an elevated bilirubin. Surgical biliary patients, more than half the time, do not have elevated bilirubin. And you can only know that sonographically, and then, of course, combining with the liver enzymes and the clinical signs and so forth. Therefore, if a clinical sonographer or sonogram is not performed early in the workup of these patients, the treatment direction is often fruitless or erroneous, or is just kind of helping a little bit to stabilize, but the underlying true pathology isn't there. And you could apply that to a lymphoma case that's getting treated as pancreatitis and presents clinically as pancreatitis, or a GI foreign body, especially the distal ones. I could go on and on and on of what actually lives in a quote-unquote pancreatitis patient. Or is there a pancreatic abscess that needs to be drained? There's so many things that go on as that classic pancreatitis is often something else underneath. And the root problem of any soft tissue pathology is often more than not imaged and interpreted sonographically, to have pathology ruled out with a negative sonogram as well. And the value of negative scan, ruling out most of our differential list, is truly underestimated, and often a value that is not properly communicated to the pet owner. The pet owner, oh, you didn't find anything? Well, I don't want to pay. You all know that conversation, right? It's like, no, we didn't find these things, therefore it's something else. I have an adage, just an old saying, if it's not in the abdomen or not in the chest sonographically, then it must be orthopedic, metabolic, or in the CNS, right? So if you rule out everything that could be bad in the abdomen, and the heart's beaten and Starling's laws are respected, then it's either in the things that's making the patient not do right, or ain't doing right, doc. You know that scenario, right? Maybe it's orthopedic pain with referred abdominal tension, or there's CNS disease going on, or maybe he's an Addisonian, and maybe he has some sort of thoracic pathology going on. So we take a different direction upon the negative sonogram, which has huge value. And so it's important to communicate this to your pet owner and to your colleagues, especially the ones that are referring you the ultrasounds. Oh, you didn't find anything. I say, yeah, I didn't find anything. That's a good thing. So this clinical sonography approach of if it's sick, it needs a probe directly enables a bridge to correct diagnostic and therapeutic direction. So I have colleagues that say, I can't get if it's sick, it needs a probe out of my technician and doctor's head. And that's a good thing, because I guarantee you they've enhanced their diagnostic workflow very rapidly. A diagnostically efficient clinical sonography exam is not only limited to the clinical sonographer's imaging techniques and machine selection and ability to interpret the image set in combination with the clinical exam and supportive lab work and radiographs. Diagnostic efficiency lies within the mentality of the clinician and the facility culture that elects sonography early or later and plays a role in the efficient and accurate outcome or not, right? So the same could be considered for computed tomography, CT, which in combination with clinical sonography and supportive diagnostics, in my view, is the most complete diagnostic effort for determining definitive diagnosis in our early patients. But that combination ultrasound CT is a subject for future discussions. But CT is getting less and less expensive, and look for that to be a wonderful combination if you're not using it already or have it in your local community. But ultrasound and CT together with needles and somebody that can handle them is a very, very powerful diagnostic combination. If you think about common pathologies that are revealed under our on-site or virtual telemedicine ultrasound probe, you should wonder, what am I missing by not doing an ultrasound early in the presentation? So these are some of the most common clinical histories we encounter in small animal medicine. The vomiting patient, the lower urinary tract patient, the PUPD patient, the respiratory distress patient, the diarrhea patient, the anorexic patient, the weight loss patient. All of these often have common, straightforward findings on ultrasound. We do it all day long. Or they have subtle findings that are very much machine dependent, as in resolution and depth and acoustic power and technique that define whether you're going to see those subtle lesions or not, and we're going to be able to work with them or not, and keep us from having a presumptive diagnosis as opposed to a specific one. So all of these clinical presentations and their respective pathologies, post-sonogram, typically the patient's going to move to surgery, intensive care, outpatient medicine, oncology, or hospice, or back home happy with the owner because we had no significant finding and we were just doing a geriatric check or an enzyme chase or something like that. If we choose to investigate further after a negative sonogram, we know that if the patient is clinically persistent and having issues and we didn't find anything sonographically, we can pivot clinically to other modalities. CT would be the next step. MRI, full CNS exam, metabolic and special testing. Maybe he's Addisonian. Maybe he has an arrhythmogenic disease. So we can see, and if you put a probe on the heart, you can see the arrhythmia, right? So we need to find those CNS, orthopedic, metabolic, and the arrhythmogenic disease that are making him just not himself. But we can only go there if we have a negative sonogram that tells us the problem is not structurally visceral. So the negative sonogram is just as important as the positive one. And the negative sonogram rules out all those visceral pathologies considered and drives us to diagnosing other things. Moreover, a probe on the heart positioned properly, even in a targeted point of care technique where you get Ep.1, the brick as we call it, 4-chamber long axis, and you see that left atrium and left ventricle, or you get a 5-chamber and you get an L8AO, or you get a short axis L8AO. That's all you need to know in an immediate point of care scenario if there's volume overload and the respiratory signs are cardiogenic or not. And that takes the case in one direction or another. Because if the left atrium is not big, it's not going to be left-sided failure. Okay, it's that simple. Everything else, yes, is important to do in a proper echocardiogram, but if you have to make quick choices, whether you're going to go to one pile of drugs to deal with left-sided heart failure, or you're going to go to another pile of drugs to deal with respiratory disease, or maybe it makes you think maybe he's having a thromboembolic episode, or maybe he has respiratory distress because he's painful, that is a pivot by a properly placed probe on the heart, 4-chamber and 5-chamber long axis, and short axis heart-based view. It takes 2 seconds to do it once you know how to do it, right? So again, ultrasound will take you across to where you need to go. And it's a diagnostic bridge, right? So the factors that lead to success across that bridge cannot be taken lightly, right? And the range of economics from purchasing the right machine and education to the culture behind and around the probe in your local and referring veterinary community are all essential to address. So you can see it's not about, I get a free machine with my lab contract. No, there's so much more involved in it if you're going to do it right. Right? And there's a lot of not right ultrasound done out there, and we're trying to avoid that. We're here to help you avoid that. And unfortunately, it's a tough love scenario. It's a reality scenario. This is the reality. None of us went through a learning curve without effort, right? And clinical sonography has an essential need for that effort to look at these different factors. So we know that ultrasound clinical sonography is a bridge to one of the 4 doors of outcome direction for any patient. This is why living by a probe for any sick patient is essential. The greater the diagnostic time employed with our clinical patients, the greater detriment will follow with our clinical outcomes, as well as economic and emotional output from the pet owner. This is all cost of missing a lesion, right? Or cost of not performing an ultrasound early. So that time frame from presentation to outcome defines a pet's finality. When the owner has an exhausted economic or emotional resource, then they pull the plug on the case. And we use the term, he died of financial disease. So it's an unfortunate, inefficient cascade that also plays a role in our psyche as veterinarians, because we feel we could have done better for that pet and that pet owner that was treated empirically for 3 days and didn't get better, and then they put him down. Everybody's been through that. I've been through that. But ask yourself, did you have a definitive diagnosis on day one in that pet? Because if you get a definitive diagnosis on day one, it needs to go to surgery to pull that gallbladder, or it's a pancreatitis, and they're going to employ their emotional and economic effort for that pet over the next 3 to 4 days, as opposed to getting to 3 days and he's not quite right and then they pull the plug. Use the effort for good, and then you will get better outcomes, and we will do what we wanted to do as veterinarians, why we got into veterinary medicine. Because we have faster diagnostic workflow, and therefore we eschew financial issues. The cost of veterinary care has gone up exponentially in my almost 30 years as a veterinarian. And so we have to continue to shorten the time frame of the diagnostic economic impact that's involved. And this is all part of that, right? So we as practitioners can thwart the economic issue by making clinical decisions, rendering economics behind the pet more reasonable and able to treat when we find early definitive diagnoses. And we call it the 12-hour rule, or 12 to 24-hour rule. Have your clinic, have your clinicians, have your technicians, everybody involved, even in the front office, with the culture of 24-hour rule. What's the answer? Get to the bottom of it. And you're going to get there more times than not by a sonogram if it's sick, it needs a probe, right from presentation. Clinical sonography performed at presentation is a big part of that 24-hour rule. And without that clinical sonographic bridge, then it's just all empirical, right? Unless you're doing exploratories. When was the last time a radiograph gave you a definitive diagnosis that you knew exactly what was going on? It does not happen very often, right? Unless it's an orthopedic issue. So, you can see a splenic mass, but do you know if there are mets in the liver or not? That's what ultrasound's for. So if I had my preference in an ideal world, knowing what I know after 25 to 30 years of clinical sonography, as opposed to knowing what I knew coming out of college or a few years out of college, I would put a probe and run a CT on every sick patient if I could, and I would package it accordingly. Moreover, I'd package the testing and make it economically feasible to make it a quick, easy decision for the owner, and have them bring their sick patients through our doors to get answers. All the economics pan out. And you build your practice that way, but you build goodwill and you become the veterinarian you always want to be. In that scenario, the sensitivity in CT plus ultrasound will already give solid direction and can be further interpreted, in case presentation can be further interpreted and refined by other tests that are being run, the CBC Chem, UA, special testing, and so forth. And I'm sure I'll get feedback from this, and what else is new? when you're pushing the envelope and trying to do the right thing, you always get feedback, right? So it's really about time someone related what we are living daily from an imaging standpoint. And when you're going in and out the back room of so many clinics, at one time I had 200 clinics that I knew, and I saw everything that was going on, and it's our decision to make the process much more fluid and much more efficient. We need to get answers for our patients and pet owners as efficient and accurately as possible to limit patient suffering, enhance the early diagnosis, and have a proactively better body state to respond to therapy, such as a lymphoma case. You have lymphoma with a spleen involved and maybe a couple of lymph nodes, boom, that goes away with proper chemotherapy. But if it's all over the abdomen and it's gone from spleen to the portal hilus into the liver, and then you have the liver involved, prognosis drops right through the door. So we have to get on it early, and the patient would be in a better body state to be able to deal with the chemotherapy and have quality of life if we get on it early. And we also limit enduring financial costs in the workup. That stop us from being a veterinarian. How many people listening right now, raise your hands, you're probably driving down the road, raise your hand and say, I am sick of financial disease with my pets. And it's one of the reasons I got out of general practice and went into specialty practice, because it was heartbreaking. When I knew that I could take that animal to surgery and they just said, nope, It's like, well, 3 days, it took me 3 days to figure something out. No, I had to change my workflow to get there faster, get to the answer faster, so I could treat them faster, so I could stay within that economic window that the pet owner has, right? If we decline to progress in the efficient, if it's sick, it needs a probe concept that we have in 2022 or 23, which we didn't have in vet school or 5 to 35 years ago, then we're limiting our ability to practice our profession in the fashion we envisioned as veterinarians. Moreover, in not taking advantage of the more efficient diagnostic workflows available today, we risk compromising our art of veterinary medicine, our personal and our professional time. The patient's quality of life is all compromised. The pet owner's emotional and financial well-being are compromised. All this plays into the cost of missing lesions that we encounter clinically. It's not as much missing a lesion, it's as much not performing the ultrasound early, all right? And not utilizing if it's sick, it needs a probe. If it's sick, it needs a probe will help achieve these goals that we're looking for and we set out to accomplish when we started vet school. Anyone listening to this that went to vet school, you could have done a billion different things, but you went to vet school for a reason. You could have made more money going to the human field. You would have made more money on Wall Street, but you spent your time going to vet school. You went there for a reason, because you wanted to support animal well-being and support the pet owner's well-being. And we have to adapt to all of the different factors that come up in making that happen. And economics and efficiency diagnostics are the top two things that we are battling, right? So the diagnostic efficiency is your choice. It's the culture of your clinic. And it has a lot to do with the cost of missing a lesion or delaying the diagnosis of a lesion. All this plays in the ultrasound selection, okay, or the capital equipment that you're going to choose. Because in any ultrasound machine, the best sword is only as effective as the hand that wields it, right? And the culture behind the training of the swordsman or swordswoman. And so you have to be trained adequately to be able to battle the battles that we deal with on a daily basis. So maybe you're overwhelmed by this conversation, which is entirely possible. Again, this is kind of an accumulation. I'm kind of regurgitating 30 years of frustration, but also 30 years of solutions, right? And the solutions are coming, I promise you. Maybe you're just thinking, I need to buy an ultrasound machine for my practice, and weren't expecting all these functional factors to consider. If you take anything from this podcast or article, just remember that clinical sonography is not about buying an ultrasound machine at the lowest cost you can and placing it in the facility, expecting the novice or even seasoned sonographer to maximize its ability to not miss a lesion. Clinical sonography is about setting up a daily educational and support infrastructure around the right ultrasound machine that's going to image everything that walks through your practice and all the parts of those patients that are entering into your practice. And improving your image set daily so you don't endure the cost of missing a lesion while enhancing your sonographers and facilities' image footprint. That's the images that you're putting out there on your report or you're moving around the internet. That is your calling card. Images on your report are interrogated by colleagues in-house, in your community, or even worldwide. And your image set in your case report represents your clinical sonography calling card. It's who you are as a clinician. I see reports from all over the world. I said, that person knows what they're doing, that person doesn't, that person needs an upgrade, that person's not investing enough. You know, or I'll say, wow, great adrenal, nice phrenic vein. Look at that common bile duct. That's who you want. That's what you want to put in front of people that are looking at your images, because that's what you stand for. You did all this work to become a veterinarian. You did all this work to become a clinical sonographer. Put an image set there that is optimized, that represents who you are. You wouldn't go to, you know, that little vending machine that makes your calling cards for $10 for $100, right? You're going to get a proper business card made. At least, you know, I'm aging myself because everything's digital now, but you know what I'm talking about. You're going to spend the money to make that calling card, that image card, your business card look really good. Ultrasound image sets are no different. They show that you care. They show that you are making the effort and that you know what you're doing. And so there's confidence behind every one of those images, right? So maximize the image quality as a core part of marketing your ultrasound business or your service and the seriousness around it. I would take if you need to budget, take money out of your marketing budget and put it towards the quality of your image sets, whether it's a machine, whether it's the education, because in the end, your image sets are marketing for you. Optimized image sets project determination and professionalism of process, and that reflects who you are and who your facility is as an entity. This is true for ultrasound, it is for radiographs, for CT, or MRI, or any image modality, even right down to that suture line that you close your spay from. You know, the owner, they don't care that you did an abdominal surgery and a hysterectomy. They want to know what that suture line looks like, right? It's the same thing. It's human nature. They want to see what the pretty result is. So be pretty, right? So essentially for this reason, your inherent costs involved in capital equipment purchase and operation should derive partially from your marketing budget. That should be fostering the mentality of clinical sonography, and if it's sick, it needs a probe throughout your facility and a referral client base. So up till now, we've talked about the theory behind if it's sick, it needs a probe, and why it's so important to perform an ultrasound early. I'm going to finish the episode now, but in the next episode, we're going to go through bullet point by bullet point all of the key points that are necessary to address when selecting an ultrasound machine and all of the factors that go in behind it regarding education and politics and so forth. So thanks for listening, and the next episode will be coming up shortly.